We'll
So
just start the recording maybe just after we get through to where we ask about it, if that's
recording earlier. Thank you so much. Okay. So our agenda today is we're going to quickly go over the CST guiding principles of design and the purpose of our meeting today for our session. We're going to quickly go through a high-level overview of enterprise workflow, as well as go through the clinic forms that you've provided for us today and review them with you, and then follow up with some additional questions and next steps. So just jumping right in here for our CST guiding principles of design. So our session today is surrounding design, which is slightly different than our previous session. So just a quick reminder about CST again. It's a clinical and systems transformation project, which transforms healthcare systems and processes to improve the safety, quality, and consistency of patient care. And the 3 health facilities involved cover Vancouver Coastal Health, Provincial Health Services Authority, and Providence Healthcare, otherwise known as VPP, which may be used as an acronym that you might hear. And our design approach is centered around the guiding principle of enterprise design. So this entails configuring the system to effectively incorporate all of the 3 health organizations and standardize its processes. So this enterprise design, you might hear that word quite often, is guided by the adherence to some key principles or must-haves. Specifically, changes to the system are implemented when the following 4 factors have been taken into account. So safety, changes that have patient safety implications, regulatory changes that are required to meet reporting requirements and international standards, financial changes that would create efficiencies without requiring significant operational cost, and content, changes to add content that currently does not exist and is required. So the purpose of this session then is to review the enterprise workflow that's applicable to the ambulatory outpatient clinics, identify any design requirements to satisfy that workflow specific to your clinic, and then review the content that already currently exists in Cerner and identify any gaps. Any questions about the last few slides before we jump right in?
No, that's okay. I just wanted to say thanks to everybody. This is a lot of work you guys have to do for many clinics, and we really appreciate the effort you put in to make it work for us as well. So carry on. Thank you.
Thank you, Dr. Graff. We appreciate the hurrahs from wherever we can get them. So jumping in, so enterprise workflow, again, this is a very, the next few slides will feature a very brief kind of high-level overview of generic steps that are involved in enterprise clinic workflows. They're not really exhaustive in any of the details that we present, but it does aim to provide kind of an introduction to how other enterprise clinics operate within the system. So as you can see, there are multiple steps here that have that we'll go over the next few slides, starting off with the clinic receiving the referral. So referrals can be received via 2 methods, external or internal. The external referrals, predominantly for your clinic, will come in through a fax to a program called the Work Queue Monitor. It's an application in CST Cerner, where then an encounter, which is a record of the patient interaction, can be created. So every patient interaction is labeled as an encounter and has its specific encounter number. The fax can then be indexed to the chart, and internal referrals are received in a different program called Scheduling Appointment Book, where the orders come through as an orders to schedule. Screening and triage. The clerk then screens for completeness of the requests that had come through, and patient requests can then be placed on a referral triage list. The clinicians then screen for appropriateness and urgency. So the clinic either accepts or rejects the referral, and the provider, the clinician, can enter an order to either accept or reject the referral. The order automatically updates the referral status for the clerk, and then the referral status can also be pending, which is if it's missing information or labs or diagnostics, for example. Again, I'm going through quite quickly, and if you have any questions, please feel free to just jump in. Moving along to scheduling the actual appointment, if it's been accepted. So scheduling the appointment, the scheduling request queue contains much of the information required to manage the list of patients requiring appointments, such as when it was received, the ordering provider, and other order details. The majority of the information needed to schedule comes from the details that the ordering provider entered when placing the order, such as interpreter is required, urgency, or reason for the appointment. And multiple resources can then be selected when attempting to schedule the appointment, which the system will suggest an appropriate time if required. So I believe most of our scheduling for this clinic will be covered in a different session. Yeah, this is just the high-level workflow overview. Confirming the appointment. So the appointment must be confirmed in the system at the time of scheduling so that it is placed on the schedule and the resources are then reserved. Confirm appointment summary details can also be included within the system, and then these details can be provided with the patient if there's any pre-appointment information necessary for them to know. Requisitions can also be printed or print to PDF and emailed to patients. So we just have a few follow-up questions here about this step. Do you ever have to print requisitions for your patients prior to them coming to see you?
I don't think so. You're talking about like a lab requisition or a diagnostic or something?
Yeah.
Not that I can recall, Grace. That's never really been a thing. Yeah.
No, yeah.
Okay. And so we do have a functionality in Cerner as well, where automated appointment reminders get sent out to patients. Wondering, I know it's early days here, and wondering if this would possibly be something that your clinic would be interested in.
I think that would be good. Don't we kind of do a little bit of that already, Grace, right? And we do have trouble sometimes with people remembering. So I think automated reminders would be a nice feature.
Perfect. We'll start gathering requirements for that. Thank you. Moving on to when the patient arrives and then they are checked in and registered. So they present to the clinic on the day of the appointment. The clerk confirms their demographics or any details. This is where the encounter, the patient clinic visit, will be flipped from a either recurring or outpatient to active encounters. So any work that needs to be done prior to the patient arriving will be in a pre-encounter. And then once the patient is physically on site, it will be a full active encounter and the pre will no longer exist and it will just be an outpatient encounter. The clinician is then notified that the patient has arrived. So moving along to documentation. So for the nurse assessment and documentation, the nurse sees that the patient has arrived either physically or in the system using ambulatory organizer. And there's just a small screenshot here of what that would, the page would look like for you. And we'll go through kind of showing you a demonstration, a quick one as well of the system in just a minute. So documentation will be clinic and task specific, and nurses typically document in Power Form, interactive view, or dynamic documentation. Again, those are probably new terms, and you'll have ample time to be viewing the system as well as practicing within it. So those are just different ways that documentation is captured in the system. Same goes for the allied health assessment and documentation. The allied health sees that the patient has arrived either physically or in the system via ambulatory organizer, and the documentation is essentially the same. They use Power Forms, interactive view, or dynamic documentation as well. For the provider assessment and documentation, again, the provider sees that the patient has arrived. They can complete the medication reconciliation and any prescriptions. They can enter lab orders within the system and document using FESR and easily customize templates. And notes can be distributed via Acceleris to various downstream systems. So we do have an additional question here. Dr. McGrath, are you responsible or other providers in your clinic for reviewing resulted orders placed by other clinicians? So do you cover other providers like results, for example, or vice versa?
Responsible for reviewing results, so like labs or whatnot. That might happen from time to time, but it's not really all that regular. Like it would, we follow our own patients for most of the time, but then we might fill in, or somebody has to, Grace might have to put them in more urgently somewhere else. So it's possible.
Okay.
We just don't really order a lot of stuff. Like it's not like we're ordering labs and x-rays and ultrasounds all the time, but it does happen occasionally.
There's an ability to proxy your list or your inbox to one of your colleagues. So if it's infrequent, that would make the most sense. You can just have, proxy it for a week and they can get your results if you need them to cover or they need you to cover.
Right. So let me just think about that. So let's say I'm following someone along, I've seen them 3 or 4 times, and then I want to order an ultrasound. So I do, it gets done. But the next time they come in, they have to see a different physician. So
well, any physician can look at someone's labs. It's more like if you order a lab and you go to Hawaii, then you can send it to one of your colleagues if the patient's scheduled in that week. And then the notification of the result will come to your colleague so that it doesn't get missed while you're away.
So it's just the notification that we're talking about?
Because anyone will have access to the patient's chart to review if they want to.
Just like now, someone could look up any of the x-rays and stuff on Care Connect. Okay.
I think we're asking because there's an ability to make it so that everyone can get notifications, but if it's one-off just coverage, then it's not necessary.
Yes, I agree, Yasmin. I think that would be too much if we were all getting everybody's notifications and 95% of the time we didn't have to look at them. Yeah. Okay, makes sense.
Thank you. Thanks, Yasmin.
Thank you.
And then it's at the end where the follow-up or the patient has departed. A discharge summary can be generated through the system if required and given out to the patient to take home. And a patient if the patient had come for a one-time appointment, so not a recurring encounter, the encounter is auto-discharged at midnight. So those are, again, high-level overview of what a clinic workflow is for enterprise. Any questions? We will, obviously, as the weeks and the months go on, there will be many different variations and different scenarios that will come up that will be, that would kind of branch off from the workflow that's presented here today. And we will address those as they come. And yeah, great. So we're just going to jump right into the forms review. And we're going to start off with psychology. Adrian, are you okay?
Hi there, I am indeed. Good morning, everyone. Ooh, sorry, there you go. You guys can see me. Okay, hey, so good morning, everyone. My name is Adrian. I am a mental health CIS. So I'm here to speak to the psychology piece of this clinic. Thanks for having me. And Angie, good to see you again. I think you were with us last year around this time for our psychology sessions for VGH. So I'm just going to be going over a few forms for this clinic. First, I'll start off with the psychology forms. Looking at this progress note in the paper world, that's what it looks like on the left. I'm sure everyone's already aware. And moving on into the Cerner world, we're looking at a dynamic document for the psychology note and the use of auto text for this. Angie, I don't know if since we last spoke a bit over a year ago, have you had an opportunity? Are you working actively like in the live Cerner domain right now? No, not yet. Okay, so just a little bit of a refresher then. I know it's been a little bit of time. What you see here on the right-hand side is what we call dynamic documentation within Cerner. and you can see those headings there. Certain things can be auto text, and we also have what we call smart tokens that can pull in certain results, and that can also get flushed out as the months come. So that's kind of what the progress note will be moving towards at the time of go live for this clinic. Any questions or concern regarding this piece of documentation? If not, we can move forward to the next. Okay.
No, it looks like it's a direct copy.
Yeah, that's what we, I mean, and please correct me if I'm wrong. I know there are like quite a bit of like different psychologists works in different areas, and they all kind of do their own note to their own style. So what we saw best fit for kind of with the psychology progress note, we tend to like to tailor it to that specific clinician, and that's where we create auto text options for that clinician that to kind of tailor to what he or she is used to documenting.
Adrian, I'm just going to jump in. So
Please.
I made this test example just to show you what it would look like to auto text, but for everyone else on the call, I think quite a bit of this clinic, because there's so many different specialties working together, I think the best option for a lot of the forms is using auto text like the such. So I just wanted everyone to take a look, even though this is a psychology form, just to pay attention to what an auto text looks like, because it's going to come up quite a bit.
Thank you for that. Okay. Yeah, why don't we move to the next form? I think my video is lagging. I'm just going to turn it off for now. So this is the pre and post operational psychology intake summary. As a group, we went over this form, and looking at it, and also once again, dynamic documentation is what we are moving towards. And just given on the confidential information that these note types can contain, what CSD has created is actually a psychology protected note that does not distribute to Care Connect or Accelerus, and it's actually not visible to other disciplines. Only people who are in the psychology positions can actually view these notes. Once again, as mentioned, we use auto text. We can use auto text for this. And this is, I guess, more a question to you, Angie. Does this documentation need to be protected? And such as it can be locked down to the psychology position as mentioned and not have it distribute?
No.
Okay.
No, I don't think it would need to be protected.
Okay. Well, that is an option, just a protected note type in general. It is an option to the psychology position. So if there is ever a document or an assessment that you see fit that needs to be like locked down in a sense, then that is going to be the note type that you'll be choosing to use.
It does contain sensitive information, but not, I'm assuming that things can get locked because of tests and things like that my colleagues do, but I wouldn't want the internal team to not have access to my reports or notes.
For sure. And that would make sense for that scenario. I think just a little bit of background, this was created, I think, back in the BC children's days. So that psychology group came forth and asked for a protected note type. So that's why now this is available to all psychologists as well.
Well, thank you.
Yeah. Okay, this is the psychology phone screen, the intake checklist. Once again, dynamic documentation and auto text to mimic what we are currently looking at over here on the left. Okay, move on. Discharge summary. Once again, dynamic documentation, and we can use auto text as well, and along with any smart tokens that can pull in certain results as well. Authorized for release of information. So this one, just because pen to paper, we are going to be needing to put this in forms fast. So this actually stays on paper, and if this form is needed, the clinician will go into the forms fast. So that's our paper form repository within Cerner, prints that out, and then we can get the patient to sign it for the release of information. And once that's been signed, this form can get scanned back into the chart. So the MOCA, we do have the MOCA within Cerner. However, because the way the MOCA is in terms of how this test is conducted, the patient actually needs to put pen to paper. So within Cerner, what we have here on the right-hand side, you can see is actually as the clinician who is recording this, you would just capture the score of the MOCA test. And then there's also a free text field where you can free text in your impression and findings. However, this test will still very much be done on paper and it's already in Forms Fast. And if you're conducting this test on a patient, simply print it out, have the patient complete it, and yeah, and then you can document your findings within Cerner. You okay with that? No questions or concerns? This is what current live sites are doing as well. So for the PCL5 checklist, this is what we have in the system is a power form, and it's available in Cerner already. For consent, psychological treatment, for this specific form, we are gonna have this in Forms Fast, stays on paper once again, since we need sign off on it. And then once again, this will get scanned back into the patient's chart. Okay, go to the next one. Safety plan. So looking at this form that was presented, we have two options for this. One is dynamic documentation, which we previously mentioned. The use of auto text will be for this DynDoc if that's the route we're going. However, this must get printed out and then given to the patient. Just because correct me if I'm wrong, looking at this form, this is something that the patient will have with them, right? Because there's like phone numbers on it and kind of like strategies and whatnot. Yeah, okay. The other option is Forms Fast. So once again, that's the repository for physical forms. And the clinician will print this out and then have it filled out by pen and on paper, and then photocopy for a client, and then the clerk can scan this back into the chart. So for the purpose of this form, yeah, so those are our two options. I'm not sure what the group is gravitating towards.
The third option that we didn't list is if you do have a good template, like a PDF that you're already using, you can always just keep it there and just scan it after the fact. So it doesn't, because it looks like there's like the click here to enter text. It looks like a PDF that's easy to fill. So you can always just maintain what you're doing. And since you guys requested a single document scanner, your clerks can just scan that into the chart if you need a copy or send it to HIM after.
So I guess the question, Dr. G, is do you want to use your template you're currently using, or did you want to type this into Cerner and then print it off of Cerner so that it's already in there?
So the first one maybe in Cerner, and then I can print it off and give it to the patient.
Yeah, it's just the text rendition will look a little bit different. So like it won't look exactly the same as the setup as this.
Mm-hmm.
So maybe what we can do is like mock one up for you of what an auto text would look like, and then show you what the text rendition is and see if that's something that's acceptable to then, because then it kind of skips the step of scanning it. So if you like the final output and you're comfortable with how it's going to print, then that's okay. And then if you don't like it, then maybe you want to continue with this. So maybe we'll just mock something up for you for this one in particular. Would that be
from
helpful?
experience,
That would actually be great.
Okay.
I was just going to mention from experience, it would probably just look like without the boxes, just straight text format.
It's going to be more like a list format as opposed to this structure. So I don't know if that'll be acceptable or not.
It would be nice to have an option in Cerner, but easily readable or legible for the patient.
Right.
If it's legible and clear, then in Cerner, it would be fine with me if it's okay with the team, because it's other team members would use this as well.
Okay, so we'll mock this one up for you and then show you what it looks like, and then you can tell us.
Great. Thank you so much for doing that.
Yep, and it's Michael here. I think it would be good to have it in Cerner, and with the rest of us knowing where it is, because yeah, I could see times where potentially a physician might fill out the safety plan if that was the first time it came up as an issue.
And are you giving this as a physical paper right now, Dr. G, to the patient? I know there's a hyperlink down there, so I just didn't know if this was sent another method or just it's paper.
Yes.
Paper. Okay. Thanks. Sorry, Adrian.
No, you're good. Thank you.
Sorry, Dr. G, one more question. Do you use Fessor at all?
I'm
like-
afraid I do not know what that is.
Do you dictate?
No.
No, okay. Just wondering the way that you make the auto text can shift if you dictate.
Okay, so the last form we have is a progress note group education attendance. So within Cerner, we do have what we call a therapeutic group note. However, that is more catered to like a group of patient attending the same group. I think I might have demonstrated last time we met, Angie, but I'm happy to do it in another session again, just to kind of give a refresher. But what that is that form of documentation is it captures what the group entails, like what this group is. And then you have a patient list of multiple patients, and you can click into each individual patient and write a little blurb on that specific patient, and then say attendance and whether they participated or not. And then each of those notes will get saved into their individual charts. However, looking at this page here, it seems like this is more, well, first of all, I guess I do apologize if this has been covered before. When you run groups, I'm guessing they're going to be on multiple patients at once, or is it individual? Yeah, okay. And then you would document in this piece of paper, and then each of them will just go into the patient's chart, correct? Okay. So there is the therapeutic group note. I don't know if that fits your need. Another thing we can do here is have this page in Forms Fast, and you can print that out and fill that out on paper, and then have the clerk scan it into the patient's chart. However, the gaps here is that the notes are written to individual patient's chart, and there's no way to chart group note without breaking patient confidentiality. And the proposal here is to keep on paper and document individually to paper chart for attendance, and also have the ability to capture attendance through the Cerner tracking and scheduling. So
I guess the question, Angie, is this piece of paper currently being utilized to document on multiple patients at the same time? Like, are you putting multiple people on this one sheet?
No. Thank you for
Okay.
clarifying that. No, each note is an individual note per patient. So there's no other names or anything like that. So each individual patient has a note that they attended the group.
Perfect. Okay, well then that can continue future state. So Adrian, that therapeutic group note, is that just a Dine Doc note that's on the individual patient?
yeah, it will be.
Perfect.
Yeah, so we as a group, we can connect offline and kind of just go over the nitty gritty of that note. But if that's the case, it sounds like the therapeutic group note will fit the need of this clinic when you're running groups, Angie.
Yes, the first thing that you described initially, yep, that made sense.
Excellent. I think that is all from me.
It is. Thank you, Adrian.
You're very welcome. Any questions for me, Angie, by any chance? I'm sure we'll connect at a later session as well. So we'll
Yeah, not
definitely
so
be
far,
able to
but thank you.
showcase. Okay,
Yeah.
but we'll be able to showcase what the therapeutic group note looks like down the road.
Thank you very
All
much.
righty, gang. Thanks for having me. And
Thanks.
you're very welcome.
Love, before we get into this, do you think we could just show them really quickly in the system a Dine Doc? Just so they have a little context. Like if
I'm
I know-
actually gonna, for the
Oh, yeah.
provider forms, I'm gonna go through it. So we'll see it.
Perfect.
Yeah.
Okay, yeah, thank you.
Thanks, Yasmin.
All right, I guess I'll share. Actually, the first slide I think is, do we have order sets on this call?
No, we don't.
No, we don't. Okay. I don't have much to say on this. I'm going to have order sets discuss it when we talk about the clinic power plans. They'll be able to best explain the best process for ordering these medications. There's a functionality in Cerner to do non-formulary meds, and you have to list all the different meds that you'd want in the cream, but I'm curious if order sets has a way of pre-populating that for you. So we'll wait for their team when they have that meeting with you, Dr. Negraf. So we'll skip this slide.
Can we just ask one question? Do you need a narcotic printer? So do you need a prescription printer for narcotics in your clinic?
Michael here. So let me just back up. So this cream one too, I'm just wondering, like, if we would modify that so it could just be filled in a little easier, like you could tick boxes or something. Would that be something we could make more electronic and a little more friendly than the way?
So typically with non-formularies, there's like a box where you can type out the different creams, but that's why I think in terms of like the details of the creams ordering, we should wait for the meeting with order sets because they build the plans and the order sentences. And I don't think anyone on this call they know the nitty gritty of that. So we can hold off on that.
No, that's fine.
But for Amanda's, but we will discuss that. You'll have an opportunity to work that out.
Right.
And then
the narcotic printer. What's that
so
exactly?
Previously there were triplicates. Now there's a duplicate printer. If you're ordering narcotics, it's handy.
Well, we do order a lot of narcotics. So how does that work? Just to explain it to me for a minute. Like, what's the workflow for when you're going to?
So you place like for example, a hydromorphone order, or Suboxone or anything, and rather than writing it out on your illegal triplicate, it actually goes directly to the narcotic printer and it prints out. It's now a duplicate, so half the paper goes to the patient, the other half goes to the chartlet, just how triplicates used to work. So the part that stays in the chartlet, it's like the government monitoring of the forms. And it's a locked printer, so you can't access it and just take the papers out. It's all locked and filled by the hospital.
Yeah, no, I think that would be good. And so like you would just type it in online on the computer and then it would go print. And
it would probably be at the clerk's desk. So then when the patient leaves, the clerk can hand it to.
I think that would be good.
Okay. All right, so team referrals. I know you guys had this team referral page, but in the system, there's an ability to place follow-up orders. And in those follow-up orders, I took a screen grab of the geriatrics clinic I've worked on previously. In these red boxes, you can see you can request a follow-up, and the follow-ups can only be requested within the clinic. So someone working at VGH in the inpatient space can't request a follow-up. It's limited to the patient has to be located in your clinic in order for this follow-up order to be visible. So that's what first safeguard. And let's say you wanted the patient to come back and see the physiotherapist for pain education. You can type in the reason for visit, any special instructions for the clerk, so they would see this on their task list. Scheduling priority, the modality, and then the appointment requested. So we have the ability, for example, the geriatric clinic did have a physiotherapist, so they have physiotherapist new, physiotherapist follow-up. You can do psychologist new, psychologist follow-up. So we can do these appointment types for every type of clinician in the clinic. And so once you submit this order, it goes to the clerk's task list, and then the clerk can book an appointment to the appropriate clinician. So this form wouldn't really be necessary anymore. And you can put any additional details in that special instructions. Also, if you wanted, the beauty of CSD Cerner is everything would be in the chart. So you don't even have to fill in extra comments because they could review your notes within the patient's chart when they see the patient. It would all be accessible to them if they were going to the PT, for example.
So, Michael, so you're asking should we make a choice about whether using that old form or this new way, or are you just saying this is the best way to do it?
This would be
On
the
the right.
best way because it directly goes to the clerk's list to book the appointment. Whereas if you do a form, it would just sit in the
Mm.
patient's chart and you'd still have to go tell the clerk to book the appointment. So this actually fires off directly to the clerk to do the work to book the appointment in however you'd like.
Right. Okay, that makes sense. We just started using this form. We just kind of made it as an internal communication tool. But I think when it says reason for visit in that red box on the left, is that a text field or is it a drop-down list reason for
It's
visit?
just a text field, but you can also use the special instructions. There's no formal way of using this. The drop downs have like the little arrows to the right. So the scheduling priority, the modality, and the type of appointment requested, which is which clinician request, like you're requesting them to go to. Those are drop downs.
I think it will work. I think it'll
And you
work
can
well.
even,
I don't know.
there's like the interpreter required, so it's pretty detailed.
Okay. Does the rest of the team have any comments or anything about that?
You'll just have to remember, I guess, the reason. I don't know if these are standard reasons for referral that you've kind of mocked up. Well, I guess you have an other as well. So I don't know if it's helpful to just have a template if you guys are set on having these as the ones for the reason for visit. It's just that's not going to be a checkbox anymore. So you'll have to remember, I guess.
Yeah, we just mocked it up to make it easier to communicate with each other, like
Okay.
why we were doing it and, you know, a bit of background, but we could still put that in the reason for the visit and instructions, kind of like the comment box. So I think that would work well.
And as mentioned, everyone will have access to the patient's chart, so they can just look at your note as well for more detail, so you don't have to really write an essay in here about why.
Yeah.
Sorry if I missed it. It's Alex, the OT here. Is there a reason why the reason for visit can't have the same drop-down menu as the stuff on the right-hand side?
I'm not
Why don't
sure.
we defer that, Yasmin, to maybe
Yeah.
Stephen? Stephen, are you able to answer that question?
Sorry, can you repeat?
They want to know the reason for visit
Yeah.
in the follow-up order, if that could be a set list with a drop down. Like so that they have the reason for referral on the left, as
Oh, you
opposed to
put me
making it a
on the
free
spot.
text. Mhm.
So yes, it could be. The question is, would leadership on CST approve such a change? But yeah, it's possible.
Is this order built for the individual clinic? Or are we leveraging an order
So-
that's being utilized at other clinics?
Not to get into too much build specifics, but to get a drop down, you need to leverage a code set. And so
Okay.
there's only a limited amount of code sets within a Cerner domain. So
Okay,
that's the problem. So it's not actually the physically doing it. It's to get the drop down, we need to create a code set. And that's the part that I don't know they would approve. But yeah,
Okay.
it's possible.
so why don't, Alex, if you're good with it, we can ask if that's possible. It would probably most likely be a one drop down, like we wouldn't have like a drop down for OT, PT, psych. But if it's possible to list all of them, is that something that you guys would be interested in if it is possible?
I think maybe Michael can speak on behalf of that, partly because, you know, it'll be the physicians using this drop-down menu. So I'm okay as long as the physician knows what they want OT for and what they know our scope of practice is. So as long as they
Right.
feel comfortable with that, yeah, the physicians would, this is what they'll be using, right? So
Yeah, so Dr. McGrath, is it something that we'd like to explore to have the drop down for reason for visit, or you think it's self-explanatory enough that the physician will know when they're populating this, what the options are?
So like, again, we just started this form, so we haven't had a lot of time using it to get familiar with how useful the pick list is so far. And I think over time that will be fine. Like, will be better to just kind of write something in. But I feel like we need a little bit of time just using our current form to know, like, is it useful to have sort of the pick list or the drop down?
One
Okay.
downside of a drop down list is you'll be limited to this list though. just so
Yeah.
you're.
Yeah, and that's what I'm saying is we haven't really had practice with it yet. So, I filled one out the other day and I felt like I was referring to all three of them, but I was kind of like almost the same thing for all three people in a way, like different aspects. So I feel like we need a bit more time with it, but I think probably the text box in the end is going to be fine once we're all
Okay,
more
so why don't
familiar.
we proceed with the build as is with the free text? And if you're struggling too, you could always have this like laminated, like we do for nurses sometimes, like have a guide or whatever that kind of says the different things that we can populate into it that kind of triggers us of what we can put in things.
Especially if
and
there's
then-
multiple options being selected, because I think with a drop down, I don't think you can pick multiples.
Right.
And it
Right,
is kind of a
which is-
pain once you start hard coding stuff, if it is approved. Then if you want to add something, because now you guys do like the acupuncture or whatever it may be, it's a process to get things added and removed. It's not so easy to just get that done. So I do think if the free text is workable, I do think that's the best option for you guys, if you can remember what the options are.
Yeah, that
Right.
makes sense, actually. Yeah.
Okay.
I might add one more thing then. I'm just curious because the reason for visit right now is just simply pain education, and we might have multiple reasons why. Does this text box, can you just continue adding in, or is there like a character limit with how kind of narrow it is?
Stephen, do you know the answer? I've never run into a character limit, but I can't say I've written like an essay in there. I think you would be able to put like a handful of reasons, but Stephen might know better. Are you there, Stephen? Because
Yeah,
often
sorry.
a lot of other physicians also use it for like I said, the other clinics, Jerry clinics, and they have to write a more thorough reason. But go ahead, Stephen.
So yes, there is a character limit. That's hard coded and it wouldn't be able to be changed. I'm not sure.
Do you know how long it is, or like would it be reasonable to put 2 or 3 reasons in there?
Yeah, just like the comment in the chat, I believe it's 250.
Oh, sorry, I
I can
didn't see
confirm
that.
that.
Okay, so that's quite a bit.
But then there's also the part below special instructions, which looks like a bigger box. I assume you could write more there if you felt like you wanted to. Okay.
May I ask one question or comment? The box that says current other service involvement, the team put this together because this is found to be helpful in it from an allied health perspective. Dr. Negrath, I found the form incredibly useful, especially that current other service involvement piece around, are there other folks involved? And that's primarily the reason why we created this form. And then that would help us kind of prompt a few things, but I wondered if there might be a drop box around that, or what the team thinks about adding something like that. And if there's other professionals involved or other folks like WCB and things like that involved, that's the second box on the left side, current other service involvement.
So you will be able, in terms of anyone working in the clinic, so if you had seen the patient, you can actually look at the patient relationships within the patient's chart, see who else has been working with this patient. In terms of
Sorry, Yasmin, I just wanted to interject. That was actually like whether or not they're involved in a private, physio or private counselor, like not within our clinic, would be outside VGH.
To the best of my knowledge, that would have to be just reviewing the documentation.
So do you think it'll get missed if they put it in the special instructions, Dr. G and Dr. Negrath? If that's another thing that you put in the special instructions, would that be acceptable? Because then it would still be in the same area.
Special instructions go to the clerk, and then the clerk can put that in their notes when they're booking the appointment. It doesn't.
Yeah, because this is more like the follow-up order, like Yasmin said, is more for the clerk to know what to book. So that's kind of the purpose of it. It's not so much.
And the clerk can relay it in ambulatory organizer when they book the information, but it's not, face up written to the patient's chart, if that makes sense.
So it's Michael here. It sounds like, so I'm getting the idea. This is a communication to the clerk tool, and our document that we designed was a communication to each other tool. That's kind of the fundamental difference here, correct?
Yes.
So in other words, then we're relying on our clinical note to be the communication tool, which is kind of what we did even before we had this form. So I might refer to Angie. Angie doesn't know what it's all about. Then she has to go to my clinical note to figure it out. And we wanted to create this to be like, hey, Angie, I want you to see this person, but by the way, they're also seeing a counselor in the community. And here's the few things I want you to focus on, and something in the comments. So it was kind of like a team-to-team communication tool, which sounds like this is missing a little bit in this other form.
Yeah, we can use like that auto text functionality again and just make like a template. The auto text works just like your dictation templates, Dr. Negraff. And so we can make those templates. You can share them with everyone in the clinic, all the clinicians, the nurse, as well, OTPT. And you would just have to remember when you use that note and kind of that template in a free text note, you can make the title internal team referral, and that would save to the patient's chart. And the next person taking on care can just quickly look in the documents for that note.
Okay, well, we just feel like we need to kind of try it and see what happens.
It's kind of, it's tough when you haven't, hands-on keys, played with it yourself.
Yeah.
You know it works.
Yeah, maybe Yasmin, after like when we're done this, we'll show you really quick what a DynDoc note looks like, what an auto text looks like, kind of how it functions, and maybe we'll get a better idea. Maybe we can look at Ambulatory Organizer really quick and see what the slate looks like.
Okay. All right, so these were the templates that you sent me. So I'm gonna share my screen and just, I quickly at the start of this meeting created one of your templates on this test profile. All right, can you all see my screen?
Yeah.
Yes.
Yes, okay. All right, so I'm logged in as a consulting anesthesiologist right now, and have you spent much time in CSD Cerner, Dr. Negraff?
No, I haven't, because I don't work in the operating room, so I didn't transition with everybody else.
Okay, well, this is essentially, it's called Provider View. So it's when a provider logs in, this is what they'll see. Nurses and psychologists and everyone in OTPT have their own customized view. This is strictly for anesthesiology. And I've gone to the outpatient chart, and I won't get into the details. I'll just go down to the documentation. So there's some quick links for documentation at the bottom. And CSD Cerner for the outpatient anesthesiologist already has these pain management clinic notes. They're bare bones. It's just a free text template. So I'm going to click on this.
And this is what we're calling DynDoc. So when we keep saying DynDoc, this is it.
This is a DynDoc. So sometimes in an email I sent to you, we can have DynDocs that have, actually, let me just show you. I'm going to just go into an admission note. So for example, this is a CSICU admission note, but you can see that some already have these templates built in. So this is what I was trying to explain in the email to you. And if you've documented in the chart, there's an area, for example, there's a history of present illness area in the chart. So if you document in that, it'll pull in. So we have notes that are like this, that are quite thorough. I don't know how well it will work for your clinic, just because you have psychiatrists as well and the rehab physician. So you all have different specialties. Usually when we build a specific kind of note, it's, if it was all anesthesia in the clinic, that would be easy, because we might be able to pull that onto that M page for outpatient anesthesiologist. But when it's so many different specialties, the auto text feature is better in my opinion. So I'm just going to close this ICU admission note. And we're back to the free text note. So this was the pain clinic, pain management clinic free text note. And what I've gone ahead and done is I've gone and created an auto text. So this button here says manage auto text. Everyone has the option to do this. You can click on it, and from here you can build an auto text. So I've taken your template and I've built it out similarly in CSD Cerner. And so these auto texts are neat because you can actually share them with everyone in the clinic. And if you share it with someone, they can, if they generally want it the same, they can save it, and then they can do minor tweaks to make it work for their practice. So they're quite versatile. And the way that you'd use an auto text, I'm going to just exit out of this. I've named it ... Negraph. There we go. And so I'll go to the top of this page. So I have the reason for a referral. It's pulled in the patient's name, their age. There's options to do drop downs. So, typos. Recently admitted to, I've picked common hospitals. You could just, if you wanted to use it like your dictation, you can just put an underscore. All these underscores would be like the next function when you're dictating to go to the next space. So for physicians, you can dictate. For everyone else, you can type into these notes, and you can really customize them as well, as much as you want. You have tokens, so you can pull in the history that's available in the chart, the patient's allergies, pull in if you'd like. These are all things I've customized myself. I've had it pull in employment and home environment history. Down here, some of the, I went in as a psychologist and I filled out some of these forms, and the results can pull in as well. So it's not everything you wanted is in here. For example, we didn't have BPI, we didn't have any of these two, but generally it can pull in a lot of information and make charting quite fast. So you can make auto text for most of the forms in your clinic, and like I said, you can share them. So for the previous slide, that referral form, we can create something like this. It could be ... internal referral, and then it can pull in drop downs like this where you can say the reasons, and the way you build a drop down, for example, it's all, I'm gonna just go edit this and I can show you. So here I can put anything I want in a drop down, and so we can do this for the referral form or any other form, and it makes it quite easy. And the way that you would share this form, oh, my Skype box is in the way. There's this auto text copy area. So I can look up any physician or clinician. I'll look up Dr. Lowe from St. Paul's. So, for example, Dr. G can go in and copy the note from Dr. Negraph. And so see, I can see all of Dr. Lowe's notes that he's created, and I can copy those to my profile. And that's how you could, if you wanted to build a note as a clinic and share it, or a template as a clinic, one of you guys can take this on, or I can help you and we can share these notes among the clinic. Does all of that make sense?
Yeah, pretty much. Does the note, so the auto text note, does that have to be shared for someone else to see it, or can, say, if mine is in there as Negraph consult, can one of the other physicians just look it up?
Yeah, just like I just searched. Well, I'm in a train domain, but we have Charles copied here, so I just searched Charles' notes and I can copy them to my own profile. I copy it over. You have to exit out of the chart to kind of refresh the system and come back. And from there, it would save. I'm going to go back to my patient's chart. When I open this, I have my ... Negraph. If I have saved one of Charles's, it would appear here, and then from here I can even go and edit his to customize it if I want to. It's there copied into my chart now, or into my profile.
So using this auto text method, someone could take what I have and they go, oh, I like that. I kind of like your headings, but I would change these 3 things, and they would just take it and tweak it and make it their own, kind of like the way even in Fluency Flex you can do already.
Yeah, absolutely.
Okay.
And that's why it's handy for those shared notes, because anyone can.
Yeah. Now that makes a lot of sense. And so auto text, that's the way you could do it. The other way that you showed, like where you have a standard ICU admission form, that would be another way, and it would just be automatically in there when you did a consult.
Yes, but as I mentioned, it's a little bit tough because each of these Cerner profiles are kind of specialty or service based. And so you going in and as an anesthesiologist, oh, sorry, my computer's so loud. You going in as an anesthesiologist, you're going to have different documentation links than, for example, Dr. G or your psychiatrist. So there are other ways to do documentation. So on the left side here, there's this button where I can go add. And here, for example, like earlier, we were talking about therapeutic notes. So therapeutic note isn't face up for you, but I can go look for that note. Where is it?
My note be under the graph.
Therapeutic intervention note. This was the psychology one that we talked about. So you can kind of look up other note types, but
Okay.
it's kind of
So
a lot of work. Whereas if you just use an auto text, you can use whatever note is available, free text note that's available to your specialty, and just type in your auto text.
that sounds the right way. And Yasmin, let me just clarify something. So even though our three physician types, anesthesiologist, psychiatrist, and rehab med doc, even though we're all doing pain management in the same clinic in the same way, when we look at Cerner, we're going to see something slightly different because we're different specialties. Is that correct?
Yes.
Okay.
Yeah.
If you're
slightly different.
Yeah, if you're a different specialty, you'll have a different provider view because it's based on position. So you'll have a different position. And
Especially,
that's,
for example, oh, sorry.
no, go ahead.
I was just going to say, like, for example, even things like we have these pages called quick orders where there's common orders. Yours are going to be more related to anesthesiology, whereas a psychiatrist will see more mental health related medications, for example, on theirs.
But okay, but will we be able to do the same things? Like any of us might want
Absolutely.
to order. Yeah.
You can order everything the same. It's just, for example, we have these like quick orders for analgesics and whatnot. It's just they based it on what would an anesthesiologist commonly order. But if you wanted to go, order an antidepressant or something, it might not be face up for an anesthesiologist, but you can just go to this orders page and order anything. The whole catalog is available, but they've just made it so it streamlines to your specialty to make your workflow faster.
Okay. I don't want to get down into the weeds on that just yet because I want to go back.
And I'll definitely I'll go into detail and teach you all of this in the future.
Yeah, for sure. But I wanted to go back to that auto text for a minute and just with the internal referral form, because you mentioned that. I just wanted to follow something up. So we could, what I think you're saying is we could create kind of a template, like a standard for the internal referral form and make it a communication tool such that I or Dr. Azar would pull it up and just quickly fill it in, and that would then be a little note for the internal communication. Is that right?
Yeah, so we could put I'm just doing one off the cuff here, psychologist, OT, PT. So anyone could take this. I'm going to just save it. So I've saved my internal referral. Let's say that was the note that we created. And I would just put ... Anyone can pull this up and pull it in. And then this one I used a drop down. So I could just do patient seen by psychologist already, or you can make multiple drop downs. So we can really customize these. And anyone can take it off of your profile and use it. And then where it would save is everyone has access to documents. And so when you save it, so for example, the assessments that I did here are saved by their name, but I'm just going to go to this internal referral form and I'm going to save it and name it internal referral. So then when I go to the patient's chart as a psychologist and I'm looking, I can just go look at that internal referral form. It's face up there. I can see that's where I'd find the information from you.
Okay.
And when you open it, I didn't really do a great one, but patient seen by psychologist, so this is what it would look like. It would just be like a document in the patient's chart.
I'm getting the gist of it. Let me just ask one more thing, if that's okay, on the forms, on the auto text. The auto text where it self-populates, it's pulling in data from somewhere else. So let's just say past medical history. So right now, I have to dictate that myself based on what I know the history is. Are you saying it's going to pull it from somewhere, and how do I know where it's pulling from?
I can show you that. So providers are divided. Some like to just dictate, but we really recommend documenting in the history section of the patient chart. All the clinicians have access to this. So there's this history section. Here you can see the different histories available, and to edit these, you can click on this histories button, and I'll go into detail with you more when we properly train you.
Okay.
But here you can add, for example, like alcohol, employment, anything. So I filled these out just to show you what it looks like actually. Yeah, and you have the option to add family history, so this is where it all comes from. If they've had any procedures, you can go in and search procedures. And so I actually did this morning. I added an appendectomy and a laminectomy. So this could all pull into your notes for you,
Okay.
as long as people are diligent. As Cerner is going live, it's going to be better now with VGH, but someone like myself who lives on the North Shore who's been going to Lionsgate, my history on my profile is pretty full. Someone who hasn't really spent much time at VGH yet, you will have to kind of do your due diligence to make sure that this history is as accurate as we get on the system. But this will build and it carries across encounters.
Yeah, I can see how that is good when, like once it's built.
In time.
Because like right now you have consults from 6 different people and they don't necessarily say the exact same thing in the past medical history, and you're never sure what's exactly right. Or Angie, when someone has like just says depression in the past medical history, it's like, well, was that real depression or are they just kind of not depressed? So it sounds
it's
like
not perfect though, because it is dependent on someone actually doing it, and a lot of clinicians still like to just document narratively in their notes, and so we encourage the use of it.
But it should get more accurate because more people are looking at it. And so are you saying anybody can correct it? Like if they're like, oh no, wait a minute, that laminectomy was 2012, not 2011.
Yes, I believe so. But you can look at the history of who's corrected it and who's typed it up. So.
Okay. Anyway, thanks. I feel like I'm getting in the weeds on that and I want to dig into it, but not yet.
It's a wormhole. We can spend time together. I was formerly the provider adoption team, so I can thoroughly help you with this.
Okay.
Yeah, so I think we just kind of wanted to give you a high level of like what she was showing Yasmin, the provider view, the M pages, the components that you can document in, that you can pull into your notes, and kind of how a dying doc note works with auto text, because we believe that will suit a lot of your guys' needs, including OTPT, Dr. G and Dr. McGrath. There is a couple other forms of functionality out there that is a power form. So that's what we suggested. I think Dr. G, for one of your forms, it's in the form of a power form. If we, that is more of like a stagnant form. So once you click into a power form, you can't click around the chart and see other things. So it's not good if you're trying to look at results, trying to look at other parts of the chart and then document. So that I think it was being utilized for one of your scoring tools, Dr. G. I think the power form, because then you can just go in and do it once, and then it saves to the chart or to the documents. And then the last piece of functionality is something called Interactive View and INO, or iView. And that's more utilized when you're documenting a bunch of frequent things. So this is iView. So for instance, more on the nursing side, if I'm doing vitals, I'm going to do vitals every 5 minutes. This would be an area where we document our vital signs. It's more like an Excel kind of format where you'll type in the numbers. So this isn't the best use of your functionality. So this is more clinical. So just to give you kind of an idea of the different forms of functionality, iView is more something you're going to document quite a few times. The outcomes are the assessments or the vitals. A power form is more of like a stagnant. I'm going to pull up my one form. I'm not going to move around the chart. I'm going to put in my one form and be done with it. And then the dying doc is more like a note where you could put the auto text in, or you could have the pre-populated templates, like Yasmin said. So, okay, yeah, Love's going to show a power form. Thank you.
Here's I was trying to find a power form. So here, the mini mental, oh, that's not a good one, sorry. These are power forms. So they're
so this is a power form. So once you're in this, it's more usually centric and specific to a certain area or a certain topic. And then you can do your score or whatever, and then be done with it. And it's not as helpful if you need to float around the chart or pull things in.
But this is in the auto text where I had, I think, the PCL5, is that what it's called? It was one of these power forms and then it pulled in the data when we went, where is it? Our note here. So you can, some power forms, you can actually pull in the data from them. So that's how they work. But I will stop screen sharing now.
Thanks, Yasmin. Yeah, so I just wanted to kind of give you an idea of the few options that we have, and then we kind of pick based on how often you're documenting and what you need to do with it. as kind of how we suggest which of the few. Love, are you able to pull your screen back up?
Yep.
Thanks,
May I
Yasmin.
ask a quick question around the auto text piece? I don't think it's.
Yeah.
I was just wondering if, for example, can allied health and then the physician's documents, can we pull from those documents and auto text ours? So for example, if I wrote a social history and then Dr. McGrath wanted to pull that social history into his report, for example, could he do that? So could there be crossover between allied health and physician?
It wouldn't be an auto text, but you have the ability to either Control-C, Control-V and just copy and paste, or you can, there's a tagging function where you can highlight an area and it's called tag, and it'll actually cite that in your note that you took this blurb from someone else's document.
Oh, okay.
Yeah.
Thank you.
But it wouldn't auto pull in like an auto text, unfortunately, from someone else's
I guess
document.
unless it has like the template, like the social history, right? Unless they document
Yeah, if
in
it's a
the
social history, but if
component.
But if she's manually writing like a social history and narrating
Yes.
that, like, then that wouldn't pull in.
Right. So it depends, Dr. G, where you put that information. If you put it in certain components, if you have access to it, I'm not so familiar with your position, so sorry, Adrian has left, but if you have access to certain components where you can pull that information automatically, you document in the component, then pull it into your note. If you put it in the component, other people who have access to it can pull it into their note as well. So that's why it's kind of nice to document in the components and not just in your note. So it's not kind of segregated in that sense. But that's what Yasmin was saying. It's extra work on the provider. So if someone has actually gone and done that work ahead of time and put it in the component, then other people can utilize that information. Whereas if everyone's just putting it in their note, and then it's not kind of on the chart level. It's on just on the note. Does that kind of make sense? So if you have access to the component and you put it in the component, then pull into your note, then Dr. McGrath, if he has access to that component, can pull into the note automatically.
That might be something for the team to consider, because I'm noticing there's a thread. So we all put in the scores. Most of us put in the scores like GAD. So that would be used by all. We all discuss some form of social history, occupational history, substance use history. So that might be something for the team to consider around that.
Mm-hmm. So that's Michael here. Amanda, I just want to understand what you said there. When you say component, are you talking about components that are in sort of like the central history, the main
Yes.
sort of history for that patient? Like, and that's the only place that things will actually pull from, is this one kind of central best history?
Yeah, things can pull from other places too, but I'm just thinking if from a provider view for the social histories, and because things can pull from the Power Form too, right, Yasmin? I think the social history is pulled from the Power Form.
Okay.
Yeah, so all I was saying was there is different things on the side here, like these are like the components that I was talking about.
Mm-hmm.
So instead of going straight to your note at the bottom, clicking it and just typing in and sending something, if you start putting stuff in, how it's thought from a provider perspective is you would work down these components and then pull the things into your note so that some of the stuff will save on a chart level and not just on a note level.
Mm-hmm. Okay.
Do they have social history on this one, Yasmin, the left? I don't know if that one's on here. Histories.
So what is that on the left that I'm looking at? This outpatient chart, is that the same for everybody? Like all of us will see the same thing there on the left, outpatient
No,
chart?
this is based on your position. So the tabs at the top are kind of based on the area that you're working. So there's an outpatient, there's an inpatient. You can see she's had them hidden. These are all the ones that this position has access to. So kind of the area that you work in, you'd pull in the appropriate tab, and that's usually the one that you'll work off of by the area. So this is outpatient chart. So for an ambulatory setting by an anesthesia position, these are the things that you mostly could utilize. This is customizable. You can move things up and down. You can hide things if you don't necessarily always document these things. But these components, a lot of them will flow on the chart level so that when you're documenting into the components, it's not just on your specific encounter or your visit. So that's helpful for other providers or anyone else who's utilizing to see this information and to pull it into their notes if it's a pullable information. So that's all I was saying for that piece.
And generally across providers, so you and your provider colleagues would generally have most of the same components here. Psychology and nursing are slightly different, and OT and PT, but generally most of it, for example, allergies, documents, these things are kind of common. So quite a bit of it is shared. There's just minor differences between the specialties.
And that
And-
works,
Okay.
right? Like, I don't know which ones pull and which ones don't, Yasmin, into the note, but I guess it depends what one have smart tokens, right? Like which one actually are available to pull. So not all of
Yes.
these will pull, but we have to see which ones have smart tokens to actually be able to have that functionality to pull. And then
And
love
this
or
is all, sorry, I was going to say this is all stuff that will go into detail and train you, and you can learn, you'll learn more as you go.
Mhm. Yeah.
yeah, the purpose of the session is just to kind of get you in to kind of see a brief of what this thing kind of is and like, do
Yeah.
you think this will kind of work for you? And then I think what we need to do in the next session is actually mock up some of the specific stuff now that we know what kind of piece of functionality you are leaning towards, and then run through an end to end in the like a demo of like, this is me and this is what I would do with my day, and kind of show you more in that sense. We just didn't want to mock up 3 different versions of things if you said that that wouldn't work for you. And then love, I don't know if we know either what part of the power forms pull in to those components or not, or Stephen, do you know? Like out of the different power forms, do certain pieces flow to these M pages?
Not to the M pages per
Okay.
se, but to the note, some of it does, but this would
Okay.
only be the provider team that would tell you exactly what, because it's all back-end coding that pulls into different notes and so forth.
Okay, so we would have to look up from the power form which pieces actually pull. But maybe when we're doing our mockups, we can see what flows and what doesn't, and then we can let you know what pieces we actually have to type in. Okay, thank you, Yasmin. That was super helpful.
Yes, thank you. Just keeping watch of the time. We'll see if we can try to get through as much as we can today. The next few forms will be for the occupational therapist. Is Alex back? Where are you?
Hello, I'm here.
Oh, hi. Okay, you're back. So we're just going to go through your forms here as well. So we have your the charting template that you have sent. Again, our recommendation would probably be the free text occupational therapy note. We can mock up for you. This is the pain disability index that you had sent. So this would require very specific scores that we can include in FormFast. So this piece of paper would then be printed, and then you would document onto it, and then it can be scanned back into the patient's chart.
Is the patient documenting on this, Alex, or is it just you?
Oh, it's me.
It's you. Okay.
And so since we're already here, I'm just gonna show you really quickly what FormFast would look like. So I am currently logged in as, pardon me. So I'm currently logged in right now as an occupational therapist in our test domain. And at the top here, there's the gray toolbar, which has the FormFast link. And it does take a little bit of time to load. So I've already pulled it up here. So
Yeah.
it would open.
Are you supposed to be screen sharing, or is this you're just talking through?
Oh, I think you're showing your slide. I think you're probably on a different monitor.
Oh, pardon me. I'm gonna try that again.
Perfect. Thank you.
Can you
Yes.
see it?
Yeah, we can see your power chart now.
Oh, perfect. Okay. So again, I'm logged in as an OT. At the gray toolbar, you'll click on FormFast, and it will open up this secondary window. And this is again, the repository of all of the paper forms that we carry in Cerner. So that previous slide here for the pain disability index, for example, would then be added to this catalog, and you can just search for it here under your test patient. I've just searched for the MOCA because we were just talking about that really quickly earlier. And if you were to select it, you can favorite all of the forms that you would like, so you don't have to always search for it. And this is essentially what it would look like.
And what's nice about this is the right-hand side. See how it, if you pull it up FormFast from the patient's chart, it prints in the patient context. So you don't have to necessarily put a label, and it has the right encounter. So then when you send that chartlet down to HIM to be scanned in, it'll be put under the right encounter. So that's the benefit of putting it form fast and not just ripping off a piece of paper off the side of your desk.
Yeah. So patient identifiers are at the top, including the barcode. And then this again is the MOCA, which will then you can print and then have the patient go on, click on it. Just you can have the print and then done. And again, you can favorite whatever you would like. So I'm just going to generically put pain. Don't know how fast this will work because this is the build domain, but essentially you can favorite whatever forms you would like and have them printed out. And that's what really quick form fast looks like.
Yeah, it'd be nice to have your few favorited with the stars or whatever, so then you don't have to search each time. So it's not too bad.
So you can find this would be incorporated into that with the patient label already on it. So other patient-specific functional scales. So there is no exact CST Cerner equivalent of this form that you had sent. However, there is a functional independence measure power form, which there's a small screenshot here. It's not quite a one-to-one equivalent. The scale is different, as well as the activity that you've listed here. They're open boxes, whereas the FIM has very specific activities that it asks you to put a score in for. So our recommendation for your patient-specific functional scale would either be form fast again, or it would be an auto text for your creation.
What do you lean towards, Alex, for this one? Do you lean towards keeping it on paper like that and printing it off, or do you want to do like an auto text like we showed with the drop downs?
Yeah, that's a good question. I might actually consult Sarah on this because the physio, so we're both the ones using this form. So we might actually end up sharing it depending on how many clients we have together. So I'm just getting used to this one. That being said, I did actually have a conversation with the OT educator who is familiar with a lot of the like OT assessments on Cerner. And they've even told me like to run by my assessment forms by then to make sure that it's up to par with what they have, and maybe I can use some of their templates that they've already created and modify them. So yeah, we'll see. And I'm also thinking for the disability index to have like a free form, like an auto text. Like it doesn't have to have the wording in between. It could just be just family and home responsibilities, and I'm putting in a number next to it. And then I could just chart note whatever else I want beside it. So yeah, I think that this one I might want as auto text, whereas the next one I might want as the form fast.
Okay.
This one. Yeah.
Great. Moving along here, this is the initial assessment form. So some sections of this form is available as part of an initial assessment for OT, which I'll show you in a second. But the sections in the red boxes are missing from the power form. So it's quite a significant amount of this form. So your medical history, the symptoms, and the recreational leisure. I'm just going to quickly see if I can show you that here. So again, back to the patient's chart, we're going to go up to the ad hoc tab here. So the ad hoc section contains all of the different power forms that we keep talking about. So this one is specific to the OTs. And then we have our OT outpatient initial assessment and intervention power form. So I'm going to chart onto that. Just open it up really quickly, and apologies for the scale of my computer here. It's quite tiny. So there's all these different sections that's incorporated into this form, such as source for a reason for referral, free text information, general information. The part with the yellow means it's a mandatory field. So consent was obtained and was given by. So that's the only mandatory field in this entire form. You cannot save this form without completing this section. Otherwise, you have all of the different sections such as diagnosis and problems, again, the social history. So in terms of what pulls into your end pages that we were discussing before, for example, if you were to add a social history here for tobacco, and as you click onto here, you can add as much information as you would like about the patient. So let's just say cigarettes. This will then pull, once you save this power form, into that end page that we were looking at earlier about the social histories. So there are certain things about power forms that do pull through once you complete them. And again, this will live in the patient's chart and it will carry on for them as part of their social history. So you can do that for any other sections here. Living environment, community support. So there's a lot of different sections here, as you can see, and it was developed as a general for OTs, again, as enterprise OTs go. So they're quite general, and based on the initial assessment form that you had sent us, the ones in the red boxes are missing. So our recommendation would be either to utilize the power form that I just showed you, and then keep the disability index as well, and the pain scale that would be remaining on paper. And then if you would like to continue using the power form, and you can feel free to take a look at all of these. There's lots of different sections, and at the bottom is a free text for any additional information. So it would have to be, yeah, any other comments about that, Amanda?
No, if you go back to the slide deck, so there's the ADLs as well in that power form. But so the ones that are in red are not one for one in that power form. So I guess the question is, do you want to utilize the power form because a majority of that is there? And then it's kind of going to be a bit of a process for you to get used to, though, of kind of the tabs that you do utilize and where that information lives. And then you would still need a secondary place to document the remainder of the stuff, unless you wanted to use the free text last tab for that. Or would you rather do another form of some sort of auto text? But like Love said, there is benefits to using the power form with the like the social history that has the chart drop down.
Yeah, I mean, I would be open to checking out the power form. It does look very comprehensive, so I'll definitely be choosing the tabs that are most relevant to me.
Right.
And is there, so in the additional information, like the last tab there, is there a way to put an auto text in there so that I just have the headings of like history, medications and stuff? And I feel like, I mean, I don't have to talk about medications. That's not my wheelhouse, but sometimes it's just nice to know. And so that I'm almost thinking to be auto-populated from elsewhere. Like, is that a possibility?
Stephen, can you do a auto text in a power form? I've never seen that before.
I just attempted to and it didn't work for me.
Okay. Yeah. So
Yeah.
we can't.
Unfortunately.
I could honestly just see myself having like a Word doc of like the words that just say like history and like onset or like whatever I had there, and just copying and pasting that in, and then just starting to write in. Do you know what I mean?
I was going to just say a copy and paste does work here. Auto text doesn't work.
Okay, so I'm okay with copying and pasting, you know, the word surgery date, pain history, pain treatment, like the past treatment, that type of stuff in, and then just continuing to fill those forms that out.
The remainder of the form. Yeah.
Yeah.
Okay. Yeah, that sounds like a good plan.
Great. And I just wanted to point out that Andre in the chat said that the clinicians from the rehab clinic had actually requested this to be on FormFast. So just a little side note there.
Yeah.
So moving on to, again, this is part of the same. So the red boxes here are missing.
Yeah.
Your OT phone intake checklist. You can incorporate this as a free text again, as a OT note. And yeah, any other, I think those were all the forms that you had sent us. Any questions about what we had shown you?
I guess my one question is, like, when I look at the occupational profile and like the fact that like recreation and leisure is not on there, like aren't all OTs across the health authority like addressing that. So I don't know, should I be bringing that up with my like OT educator and seeing if that's something like as a whole they would be adding?
Sorry,
Yeah.
what?
She's saying the leisure part isn't a tab on here.
Oh.
Recreation leisure. So the ask is, should recreation leisure be a tab? Would it be a free text tab on here, Alex? Like, would you picture it just saying recreation/leisure and then being like a box that you free text, or what would you picture in that box?
Yeah, I think that would be suitable.
Okay, so maybe we can just follow up with Andre about that request. About possibly adding a tab for that in that power form. And then there's two versions of the power form, right? There's the intake and follow-up, right? It's the same kind of thing. So there's two power forms like this, Alex. One is the initial assessment, which has a lot more information. And then if required, there's a kind of a similar version of it called the reassessment. So it just has less information. So I guess it's assuming that you're seeing the patient again and you don't need to necessarily document so many of the histories. So it's more of a condensed version of the first one.
Awesome. And one more question. Sorry, the red thing, does that mean it's like a star that I can like star which ones I use most often? Or is this just something I'll have to remember which ones I like to use?
No, it's a mandatory field. So it's flagging
okay.
you to say there's a mandatory field in here and you're not going to be able to save or commit this to the chart unless you fulfill that mandatory field. So, and then the yellow will show what it is. So that is the downfall of the power form, is it is a bit of bouncing around and it's not customizable. So you're not going to just be able to like flag or like flag yourself to know that I need to go to these 3 areas and document this. So that is the downfall of a power form. Is the OT reassessment one where you'd like to see the recreation leisure as well? Would you be asking that a secondary time after the initial assessment, or would that be kind of just the initial?
Yeah, it would be something I would reassess, because if their goal is around being able to improve their ability to go hiking, then I want to be able to comment on that.
Okay, so we'll follow up. That would be a change request. So because it would impact enterprise, so everyone who utilizes that form would see that extra tab. But we can put the request forward and see if it would get approved.
Okay, thank you.
Thank you. Moving on to some nursing forms. Are you on the line? Yeah. So nurses note here that you sent us, this would be equivalent to DynDoc, which would be the next note. And the your pre-op template, pre and post-operative template with the little check marks here. Again, you can use the narrative note, the DynDoc, with the auto text. Feel free to jump in if you have any questions. So this would be your post-op, your phone follow-up assessment. Again, there is an ambulatory adult assessment power form that has social history and substance use sections, which can populate in the chart as well. So I can quickly show you that power form. So I'm logged in as an ambulatory nurse. And as you can see from my homepage here, my M page as an ambulatory nurse versus my homepage as an occupational therapist, the charts that the views that you have are based on your positions, but they are also very, very similar. So the same sections that are here are viewable by different clinicians and providers. One section that, since I'm here already, I want to point out is the team communication. So it pretty much describes what it is. So you can actually enter action items here or situational awareness and planning. I'm not sure if this would be cool that your clinic can use. Also add things like seen by OT. And then you can click this icon that says available to all, so all clinicians can see this, not just the users in the same login. If you save that, then that is something that everyone can see within their display. So if I was to refresh this, and my team communication is somewhere. Oh, see, now I am an ambulatory nurse, and that note that I had put in as an OT now appears in my view when I open the same patient's chart. So in terms of team communications, this can be something that you can utilize as a team. And when the patient is, being discharged or whatnot, you can clear it or delete it. Again, the delete function here, as it is still part of the patient's chart, it can be deleted. But as it says here, it's discoverable, meaning that if it was to go to court or whatnot, that little message can still be found as part of the patient's chart. So that just wanted to show you another functionality within the system if you would like to use that as well as like an informal team communication area. So back to ambulatory nurse, I'm going to open my file folder and I'm going to chart on my ambulatory adult assessment. So again, this is another power form specifically for ambulatory nursing. And if we go back, so you can either use this power form, which will capture a majority of this information. You can use a dynamic doc, but you would have to set that up as well with the auto text for all of this information that you have on your form. So just to go back to this power form, problem list is located here, where you can add different problems for your patients. Again, this is a section that will pull through to the different M pages. You can update their allergies or medications. Medications would be if you were doing best possible medical history. Again, the similar histories section here, as well as anything for procedure or surgical history, you can update it if you'd like. These are the red dots, the red asterisks that were found in the previous power form, indicating that there is mandatory sections, so the yellow fields. So you taking measurements, for example, doing blood pressure. So as you can see, these are mandatory. So if you were to use this power form, these red dots require information to be inputted before you can actually save it and finalize this document. So this is an option for you, Lana, if this adult assessment power form is something that you would utilize in replacement of your intake forms.
Thank you, Lavelia. It's Lana here. Yeah, and unfortunately, most of, if not all of my intakes are done over the phone. So I don't take the vital signs or measurements and such. So I don't necessarily feel that that would be a good choice for me for that particular power form. Yeah.
So then maybe we're leaning more towards like the Dyn doc with the auto text, kind of like what other people are doing. Okay. And then is that what we suggested for the ones above too, Love? The other forms? So this one, Lana, would that work for you as well, doing the Dyn doc with the auto text?
Yeah, I don't see it. Yeah, I don't see anything else that kind of resembles that you already have in the system that would help with the triaging notes. The forms that I sent to you, I mean, in all actuality, they're all pretty much similar in a sense, with the slight little differences, because I do pre and post op, but the information that's captured is very similar. So yeah.
And then,
but sorry, go ahead.
So sorry, if we just start at the top really quick, Love, 66, so that is just a blank one, right? And the stuff on the left is just the form number, right? That you have, it's just a generic thing.
You know, I don't really know about those phone numbers. So all of these forms that I have sent to you, I have created myself way back, actually, with another nurse, that when we just started our clinic back from the inception. So we just use what VGH already had. And in all honestly, I'm not really sure what those numbers are next to it.
Okay,
So
but they're not patient numbers. They're just something to do with
not at all. Yeah, exactly. So those can be completely omitted.
Yeah, so that's a free text. And then this one we could do a template for. And then the next one we're suggesting also doing a template for. Is that correct? And then this is kind of the continue on, right, love? 69 and 70 is all the continue on?
I believe so. I mean, I wonder, like when we say template form, so populating some of the information from like, you know, medical surgical history and such, and substance use section as well. I do have it as a ticky form, I guess, but yeah.
Yeah, what if we did like the drop down? So kind of like what Yasmin had shown. So if you had social history and then maybe the drop down arrows with the options, yes, no, retired, maybe that could work.
Yeah, absolutely.
Okay. Yeah, and yeah, we did notice they are very similar forms with, like you said, just like differences. Okay, so I guess that's what we're going to suggest for all of the nursing forms. Okay.
Great. So our last form is your interdisciplinary discharge letter.
So I can speak to this one, love, if you want. So basically, there is not a great way to build this out. There is the option of the power form to be a multi-contributor, in which we would have like a different tab, one for psych, one for OT, one for PT. Then you guys would go in and populate that power form, and then it would commit to the chart. But the text or rendition is not great. So, and then you'd have to look at the different versions. So I guess the question is, do you want to explore the functionality of a power form where you have a set form that you kind of have to re-review and then create a new version and kind of see the different versions of the power form to see where it's at? Or would you just be happy to keep this one on paper? Paper might be a better option for this one just because this one floats around so much and it might not be as easy to read the text renditions of the different versions to kind of see where it's at. It's kind of nicely condensed here. So we were just seeking your feedback on that one.
I don't have any feedback because I don't fill this out, but I'm not sure if Angie and Lana or Alex have any thoughts on that.
I don't think so. I think the Form Fest seems to be an okay option for this.
Okay, and then it would live in the chartlet kind of for the journey, right? And then once the patient is discharged, then it would be scanned into the chart. Does that make sense? Or would you want it scanned in kind of as each person fills it out?
Only the final, I think, right? When it's all done.
That's what I'm thinking. Okay. Yeah, just wanted to clarify. I think that's a good plan.
Earlier, I think somebody had mentioned patient departure discharge summary would that be sent out to the family GP? Because this one we would send out to the family GP. Is that the same thing that you were referring to earlier? Something about a discharge summary?
I'm not sure. Did you mention it?
If a discharge summary is written by a provider, it's submitted by a provider, that will distribute to the primary care physician and any referring physician, and it'll also go to Care Connect. I'm not sure about other specialties services, but I know, for example, if Dr. Negroff did one, it would distribute. There's also a discharge handout that's for patients that pulls in more patient-friendly information that you can give to the patient. But I'm not sure about for psychology or anyone else if it distributes. I only know the provider side.
What are you doing current state with this? Are you faxing this to the GP after?
I think Grace might know, but yes, it should be faxed to the GP, this one, after we're all done.
Okay, so if we left it on paper, we would follow the same workflow, or it would stay on paper and then it would be faxed to GP and then scanned into the chart.
I think so.
Okay.
I guess, sorry, I have a question around this. When we're printing it, is the expectation then that we're like handwriting everything in, or does every clinician have the opportunity to type in it?
What are you doing current state? Are you typing in it?
Yeah, everyone's typing.
Okay, well, you could remain current state and type it and then just print it at the end and then put a specific label on it. So that it can go into the chart. So I wouldn't do the form fast then. I wouldn't put it in form fast because that's just going to make you handwrite it. If you're currently typing it, I would keep your current state typing and then I would just put a label in at the end so it can get scanned in properly. Does that make sense?
Mhm.
Because I wouldn't want to take you away from typing to handwriting if that's what you're doing.
Wait, and can I ask then, like, where is this document that we can all then contribute to typing in on it?
What do you do current state? Where does it live?
That's a good question. I haven't done one yet, so I might divert that to the team.
It's in a shared drive, and then we notify each other, hey, I'm done my section. And
Right.
then the other discipline would come in and into the shared drive and we would all fill it out that way.
Right, so we wouldn't be changing that process if that's how you wanted to continue.
So there's no way to do it in Cerner where everybody can type in, and then when it's done, you can print it and it is faxed. Is that correct?
Yeah, there is a way. It is the power form method. So we could build it as a power form. I don't know if it would distribute, Stephen. Once they're finished the power form and the documents, can you send it out? I don't think it distributes, right? They'd have to print it and fax it.
Well, you can attach it to a message center, or you can,
If they're
send it-
internal.
Yeah, internal. For external, no. Yeah, you're right. But for internal, yes, there's ways to message and send the form as an attached message in message.
Yeah, so it's a question, I guess, of Dr. McGrath and everyone. If you want it in that power form method with the tabs along the side, you would open up the power form, you'd click on your tab if you were Visio, and then you would type in what you need to type in, and then you would commit it to the document section, and then the next person would go in and do their piece, and then at the end you could print it and then fax it. There still needs to be that internal communication between you guys to say like, hey, I'm done, because it's not going to flag anyone to let you know that you've done your piece. But that's the question is it easier to keep it in the system that you're doing? Or is it better to put it into a power form and then kind of work off the power form? And then it's just a text or rendition of a power form. It's not as pleasant as this with the boxes and stuff. It'll just kind of list everything. So if that is acceptable.
Oh, so you're saying it's not quite visually quite as appealing.
Exactly. So that's kind of why we thought of keeping it current state, but it definitely would be an option. It's kind of, yeah, that's why we're asking what you kind of think.
Amanda, there might be another option
Okay.
to use it as a message center template, and then just have it enter the details in that template on message center and have it saved to chart.
Do nurses have access to Message Center and OT and PT? Because I know physicians do, and I think psychology does.
Not all nurses do.
Yeah.
So we'd
Yeah,
have to
so I
look.
don't know if that would work for
Okay.
everyone in the clinic.
So we can look into other options, I guess, to see if that's an option and propose that. And then with the power form as well, we would have to just get that approved to get that built, because it'd be viewable for kind of more than just you guys. So we would have to get that approved. So I just wanted to get your feeling of if you think it's worth exploring the power form, or do you have your heart set on how it's kind of laid out and doing the current state?
It's hard to say.
Yeah.
I think I don't know what the team thinks, but for efficiency, if it was all in Cerner and then we're all able to do that, I'm not too much. The format, I think the physician could probably figure
Read
out.
it still.
Yeah,
Okay.
read it still, but I don't know what the team thinks.
I mean, I guess what I was wondering is there a benefit to putting the effort into having it into Cerner versus the current state, or is it really, there's no necessary benefit?
The benefit would be that everyone can see who's done it. It's not kind of sitting on a piece of paper somewhere. Everyone can view if their piece has been done in the system, and you don't have to scan it back in. So those are the two benefits, that it's already in the system. Okay. It's live, it's current. If you want to look to see if the psych has done theirs, you can look and see. You're not trying to find that piece of paper or wherever it is in that other system. So that's kind of the benefits of doing it. The consequences is it. Sorry,
does it also have like the patient identifiers on it if it's in Cerner, like automatically, or do you still have to put a sticky on it?
No, you wouldn't have to put a sticky on it.
Yeah,
because it would already be in the chart. So it
okay.
saves some steps. The consequences, it's just not textually pleasing as the textual rendition when it's actually done and saved. So that's just the consequence. So it's just where you lean, but we can explore the power form option if that's kind of what you're leaning towards, so that it's already in the chart.
Would it be possible to see a mock-up of what the power form would look like that, you know, visually more textual rather than nice boxes?
Mm-hmm. Yeah. I don't know if we have time in this. Love, do you have
No,
time
that's
just to?
fine.
Okay. But yeah, I think what the next step is, if you want to explore the power form, is we would ask to prototype it. And then we would prototype the power form, and then hopefully we'd have something to show you in the next session of kind of what we would propose. And then if you hated it, you could stay on your current state, but maybe that's the next step for this one.
That sounds good. Yeah. And Alex, you think that might be a way to try?
Okay.
Yeah. Okay.
Okay, sounds good. We'll ask for approval for that one. Single document scanner. So we're going to be reaching out to, I guess, maybe Grace, you, and we've heard that you guys have requested a single document scanner. So is that still a request in which you would want to be able to scan it in yourself? So the consequence with that, Grace, is it's a few extra steps for you to actually scan and associate the documentation to the correct encounter to the correct chart. If the stuff can wait, I think it's about, don't quote me, but I think it's a 48-hour window turnaround to HIM. So if you kind of kept the chartlet going and then you sent it down at the end of the patient's journey, it would take about 1 to 2 days to actually get it into the live system to see. So the question is, do you require the single document scanner in which you want Grace or some sort of clerk to scan this information in for you so you don't have to wait? Is it worth the work? Do you require it? Oftentimes this is utilized in an area where the workflow is a nurse sees a patient and then right after the provider sees a patient and there's like some specific information that they don't want to have to wait for that's on paper because there's a diagram or whatever that's going to be clinically relevant, that they don't want to have to wait the time difference in between. So they
Amanda, I remember before Tiana left, she requested this, and she's managed quite a few clinics already that have gone
Yes.
live. And I think it was her request to have this.
Yes. So I was just double checking if that's still the request between Grace and, is Pinky on? Pinky might have left.
For me, I don't remember the pros, cons. I do remember Tiana saying that.
Okay.
The only, like the one I was just thinking, like sometimes Lana, our nurse, does her intake sheet. And then we would look at it. Sometimes it might even be the same day. Like she might have done it, and then I'm going to see the patient like an hour later, and then I've got the sheet printed. But is that going to already be in Cerner?
That will be in the system, so that's not as applicable.
Yeah. Okay.
I think it would be useful for the, you guys said you did surveys, right? Prior to the patients coming in? Now you're mixing up clinics.
Oh, they do the red cap.
Yeah, so if
Yeah,
you're
but
doing the red cap surveys and you want those in the chart, and you want to be able to immediately see it, and you don't have time to send that to HIM, then you would need the document scanner. Or you could just
maybe that's
hand it over on
or-
paper and then have HIM do it later, but that's, I think, the reasoning that I recall.
So we can
Yeah,
totally
that's
proceed with a single document scanner. So we'll just send some of the questions that we need filled out maybe to you, Grace. Just it's specific to where you're going to put the scanner and what computer and stuff like that.
Okay, that's great. Thank you.
Okay. And then if we go to the next slide, ambulatory organizer. So we need to figure out how you want your rooms labeled. So ambulatory organizer is kind of like your online slate, which is going to say like what the patients are, what the procedure they're in for. And then if you want to put them in a specific room. So this is handy if the clerk is going to say like update it and put what room they're in. We want to know what you want the rooms displayed as.
Well, right now we do call it room 1 or exam 1 is fine, and room 2, and then room 3 is technically Angie's room, but we all kind of know it as Angie's room. So okay. I'm not sure if that's, because I think we have 3 rooms basically, Grace, that we can regularly book people in. Well, also the PT room. So what do you think, Grace? What's the best way to label them?
Yeah, exam 1, exam 2, and then Dr. G, which is a psychology room, we call it. And then yeah, PT room, and then Lana and Alex shares the room. So I don't know how you're gonna distinguish that in there.
So with the rooms, when you go to book, there's like a drop down, and some people are fussed about this and some aren't. But if you want it to kind of be in order, typically we stick to like, you know, 01, 02, 03, 04, so that it's just really
Okay.
clean. Whereas if you're putting Dr. G and stuff, it's gonna kind of mix up. It's an aesthetic thing, and then there's also character limits as well. So
Yeah,
so that's why usually we either
it seems,
keep it. We typically tend to keep it what the room is, like 4306 or whatever that is, or just exam 1, exam 2, exam 3 to keep it consistent. Just thoughts.
Would it
that
be
makes
okay if
sense.
we did 1, 2, 3, 4? And then you guys would kind of know which one is Lana's room and which one is Dr. G's room, like if that's always 3.
I think it's probably best to do up to 5, because when we've been
5.
really tight on space, I have been in this room with a client. So not ideal, but it happens.
For sure. It's good to have it built out in case you do utilize that other space. So
If
1,
you
2,
guys
3,
are-
4, 5.
Sorry, go ahead.
I think that makes sense. So 1, 2, 3, 4, 5. Like 1 would be where we already know 1 is. 2 would be 2. 3 would be Angie's room. And then if we continue around counterclockwise, then 4 would be the PT room, and 5 would be the nurse room. But like what we technically call Lana's room. You know what I mean?
Perfect. Yeah, that works for us. Communication options. So as we spoke on something a bit earlier, message center, it's kind of like an internal email. So not everyone has access to message center. But I guess the question, what is the question here? Is there a question, or is just introducing message center?
Is there a note below? I remember there were some notes.
I think it's on the next slide,
Oh.
or is it?
The person who put these in for us is not here today.
Yeah, sorry. So anyways, we can show you message center in our next demo. It's just a piece of functionality. It's kind of like an internal email. So we can go to the next slide. Message center pools. So we'd spoken earlier, Grace, with you, I think in the scheduling session, that said it might be helpful, and Lana, to maybe you and Grace have a pool if you have access to message center. And what that would do is it would allow you guys to have a shared area to look at messages. So if you're kind of covering each other or kind of really closely working together, as well as you could add the other covering clerks in to the pool. So if Grace, you take vacation and you want other people to have access to the messages that are coming through into that pool, that's helpful. So we were just confirming that Grace and Lana, you're okay with, we can create a pool for you guys to kind of have central messages set to. Do you guys require in the clinic any other pools? Is there anyone else that would require like a central area for messages to go to that you all want to view each other's messages? You can send one-off messages to the person. It's just whether or not you kind of want an area to like, it's usually for people who are covering each other. Like clerks usually have a pool. So when they go on vacation or whatever, or hand off to each other, someone is viewing those messages. I'm thinking it wouldn't be useful in any other sense besides the one pool, unless Dr. McGrath, the providers all want a central pool to have messages sent to.
You mean a provider pool, just like all the doctors in one pool? Maybe. Yeah, maybe. Like right now, we often do things on WhatsApp or Signal, but it might be kind of, yeah, that might be good. I could think potential options for that.
Okay. Okay. And then,
sorry, it's Lana here. I just wanted to clarify about the message center pool. Is that something that when Grace is away, it's another clerk that kind of takes over her sort of being away? I'm not really fully understanding, because we're currently using Skype and other forms of, you know, connecting like Grace and I. And so I wonder what the role of the message center pool would be for me and her.
Yeah, I don't know if you would need it or not either for you and her, because you could still send Grace a message. via message center. If you have access to it, you wouldn't necessarily need a pool. So maybe it would be best just to kind of do a provider pool and then just a clerk pool. Because does anyone cover you, Lana?
No.
Okay. And then same with Alex. You kind of are solo too, right? Like everyone else is kind of in their own area. So maybe just a provider and a clerk pool would be helpful. Okay. And then I'm guessing that Dr. McGrath and Grace, you guys could be the responsible people of the pool, which I think means managing like who gets added or removed from the pool. Stephen, is there any other responsibilities of the managing person of the pool? Stephen?
Couldn't get off mute fast enough. No, not really.
Okay, I just wanted to know what it means. Yeah.
Well, see, because you have the ability to opt in or not opt in. So the individual user can opt in. If they can't, then the team lead can assign them to the pool if there isn't that ability. So yeah, so they kind of manage the pool a little bit, but there's not really that much responsibility that they need.
Okay, so that's the purpose of the team lead. So Dr. McGrath and I think Grace, if that's okay with you guys, we could make you two the team leads of your individual pools. And then what is the refusal inbox administrator? What does that mean? Stephen?
So refusal inbox is if an order is placed for cosign for the doctor and then they refuse that order, it goes into a refusal inbox. And then generally there's training involved or disciplinary actions involved. So whoever is the administrator would have to oversee that pool for any refused cosign proposed orders that the doctor's refuser.
So that's not as applicable to this clinic then, right?
Not sure. I mean, I don't think so, but you know, there might be an outlier, one or two.
Okay. And then that's not necessary for all the pools, right? Case conferences.
So that's a different pool. So there would be
the refusal inbox is a different pool.
Correct, you got it.
Okay. So I guess the ask is, Dr. McGrath, do you ever have to review orders that people have placed and then refused, like the co-signature? So place an order, the nurse place an order for a co-signature and then someone refused it. I don't think that's probably a common workflow.
No, that's nothing really that's come up in the outpatient clinic.
Okay.
Perfect.
So we can skip that one. And then Dr. G is wondering if it's maybe a good idea to have one for case conferences. So then Dr. G, would everyone in the clinic have access to that pool? Like you'd want it to be an interdisciplinary pool, right?
Yeah, an because I'm just reading around patient care and things like this, and this is something that we've just started, so I wonder if it might be helpful.
Okay.
So we wouldn't actually need to know those names. The team lead can assign whoever is appropriate to each pool once the pool is built. So.
Okay, and then who would be an appropriate lead for the interdisciplinary case conference one? Who's the best person to kind of be in charge of that pool?
I'm thinking Grace, because she does a lot of organization around this, or maybe even Lana.
Grace, would you be okay being in charge of that pool as well? Again, doesn't sound like it's too much responsibility.
Sorry, it should be fine, yeah.
Okay, perfect.
Is the pool, does it look sort of like a chat room?
It's more like an email. Looks like an email.
Okay.
Is that correct, Stephen? More like an email, right? It's not like a chat room.
Yeah, it's more like an email, but you know, these messages can include several people and it kind of becomes a chat sometimes. I always make sure that I say, you know, watch what you say in these things because it does get saved to the chart and is searchable. So, but yeah, sometimes they use it as just a kind of a group chat, but yeah, it's an email thing.
Okay. So then this is just an example of, well, I guess, yeah, we can skip the pools one. Perfect. Clinic flag. This is the last question. Do you need to know if patients that have been seen in your clinic are now being admitted to a different area of the hospital, are being seen in ED? Like, is it important to be flagged at the clinic level to know that the patient that's being seen in your clinic is down and emerge?
Yes.
Okay. So the option for this is to build you a clinic flag so that someone can add that flag to the chart. And then, Stephen, that message goes to message center, correct? If they're flagged?
Yeah, so this is a unique workflow, and let me kind of explain. So patients can be flagged at registration. Is that if they are a critical patient, frequent flyer, if they go to your clinic a lot and go to other clinics and so forth, you can flag them at registration. So what happens is if that patient is then admitted into a hospital, any of our hospitals within the Cerner network, you, the provider, would get a message in their message center saying, listen, hey, this patient has been admitted. So that's what that workflow is.
And would that go to the provider or would that go to a pool, Stephen?
That would go to the provider.
And then how do they know which provider it goes to? Or does it just link to all the providers?
It would link to the provider registered. So it would go to the provider on the registration that's identified at registration. It's like the
like when the clerk schedules the patient in, right? They're usually
correct.
scheduling to a provider, and then that
Got
would
it.
be that relationship's in the patient's chart.
Okay,
But
so the provider who's seen the patient historically.
Correct. But if that provider is associated to a pool, then that message would not only flow to the doctor's message center, but also to the pool that doctor's associated to.
Okay, so to only flag the provider. Correct.
Okay, I think I misunderstood it slightly because it sounds like you'd use this for particular patients. Like, okay, I'm really worried about this person, going to emerge, and I want to know about that. But what I was thinking is we kind of want to know for everybody, like, did they get committed to emerge or are they in the hospital? More of kind of like a, just letting the clinic know that this person's now in the hospital because they have upcoming appointments in the clinic and they're not going to be there. So, you know what I mean? It was kind of more general rather than particular.
Isn't it more general, Stephen? Because it's not going to be Grace who's putting on the flag, right? It's going to be like if they come through ED, it's going to be ED's clerk putting on the flag, right?
The clinic, from what I recall, Amanda, it was when the patient gets scheduled to the clinic, they get the clinic flag there. It's just when Cerner picks up that the patient's gone to ED, it will alert, I don't know who at the clinic, I just know the clinic, whoever it is. And that's also just to follow, if your patient's like deteriorated or whatever the reason is, so you can clinically keep track as well.
Okay, so what you're saying is Grace could put the flags on all the patients that are seen, and then if they hit the different areas of a Cerner site, that by virtue of having that flag on the chart, that's what signals message center to the providers to say the patient is elsewhere.
Correct.
Yes. Got it.
And so then if it gets too busy, then you can revisit those flags next time the patient comes.
Perfect. And then Grace can remove the flag at the end of the visit, like when you're prior to discharge, right? The patient, so then they're no longer following.
Yeah, correct. Discharge or at check-in.
Okay, so sorry, Dr. DeGraff and everyone for the confusion. It sounds like it is a generic thing. We just have to build it so that you have the option to add the flag so Grace can put it on and you can put it on all the patients. Okay. So we'll add the flag. So then next steps is we have a few follow-ups. So we will mock up that safety plan and send it to you, Dr. G, to show you the textual rendition of the auto text to see if you're happy with that. We will get the narcotic printer ordered. We'll follow up with a single scanner, and we will follow up with the possibility of adding in the recreational/leisure into the initial and reassessment power form. And then we will prototype the other auto text that we discussed as being in the DynDoc auto text. We will follow up about prototyping the power form to see if we're allowed to do that for the multidisciplinary, the discharge one. And we will build the pools and add the clinic flag. And then the next session, the hopes would be that since we have your feedback, we would just do in the test domain an end-to-end demo of what it looks like from receiving the referral from Grace's end, how you would attach that referral, how you would create the encounter, schedule the appointment, how the referral triage process would go through for the accept and reject, whether the patient's going to be accepted or rejected, and then how the clinical documentation for each of you would look. Does that work? As the next steps, and I think you also might have another scheduling session, maybe it's with you, Grace, as well. So we'll meet back in a couple of weeks. We also need to meet with the physiotherapists because they weren't able to attend the session. So we'll do a side meeting with them to kind of gather their requirements and show them their documentation, and I'll hopefully meet back as a group in a couple of weeks. Perfect. Thank you for your time. Sorry we went over a little bit.
Thanks so much.